So, let's start today with chapter 2: How to tell if your child really has ADHD. When your child has an acute sore throat, a pain, or a rash, you take him to the family doctor who probes with educated hands and identifies the cause. Then, just as capably, the physician prescribes a remedy for the problem, which typically works sooner or later. Your life and ours would be so much simpler if there was one test that would accurately pinpoint ADHD, followed by a simple treatment. Unfortunately, no such single measure or remedy exists. Like many other behavioral disorders, ADHD is very complex. There are similarities among children who are diagnosed as having ADHD, but there are also huge differences. Two children may overlap in some symptoms but diverge greatly in others. The severity of characteristics displayed by individual children varies greatly, making an instant diagnosis virtually impossible. The symptoms may not be apparent in the doctor's office or in any one to one situation, yet be immediately visible in other situations. One child may be extremely hyperactive, another fairly quiet but highly distractible, and a third child may not display any severe symptoms but still be moderately affected by impulsivity, distractibility, or overactivity. Diagnosis is not an all or none proposition and definitely not as clear cut as finding out that your child's fever is due to an earache. A diagnosis of ADHD requires the coordinated efforts of several professionals asking the right questions and using a variety of questions tests to eliminate problems that mimic ADHD. In this chapter, we will lead you through the steps that should be included in diagnosing ADHD, eliminate as many mysteries as possible, identify the professionals who might be involved, and present questions you will want to ask along the way. Early warning signs of ADHD. The diagnostic process may have begun with you. When did you have that first hunch? There might be another explanation for your child's behavior. The recurrent behavior patterns of some toddlers lead their parents to suspect the child has some sort of problem very early, but for any number of reasons, a final diagnosis may not come until years later. With the increased publicity ADHD has received, parents more familiar with the disorder begin to speculate about the problem much earlier. It is not at all unusual for a parent of a 2-year-old or an infant to inquire whether it is too early to diagnose ADHD. Years ago, most inquiries came after a child first entered school. Parents are now much more sophisticated about potential problems and are less reluctant to seek professional advice for their children. The experiences of Ivan's parents illustrate many of the early characteristics noticed by parents of an ADHD child. Even before her child was born, Ivan's mother thought he was unusually active. More than merely kicking, he seemed to be roaming in the womb. Although the experience contrasted with that of her first pregnancy, mom chalked this up to the fact that her second baby was a boy. In fact, this maleness received much of the blame for Ivan's excessive activity. When he climbed out of the crib, his coordination and dexterity were attributed to the fact that he was a boy. As a toddler, when he continually got into everything, It was because he was all boy. And when he had difficulty going to school and seemed to need very little rest, it was because dad roughhoused with the little guy. The combination of trying to maintain a workload, keep up with Ivan, is in the daytime and manage on very little sleep themselves frazzled both parents. Finally, in a desperate attempt safely to contain their child at night, they put a latch on Ivan's bedroom door. Imagine their horror when they discovered their 4 year old son had climbed out the window and was riding his tricycle on the front walk at 5 a.m. Ivan did not calm down over time. By age of 5, two preschools had strongly suggested that he might be better served by other programs. There are not many children who are so clearly hyperactive as Ivan, but his story does depict a number of the symptoms many children who are later diagnosed with ADHD have in common. Since these children do not seem to require much sleep, bedtime and nap time become constant battles. When they do sleep, they toss and turn, twisting the bed sheets into a pile of knots. These children are never quite still. First, they try to climb out their high chairs, perched in a rail chair. They wiggle and rock until the moment they are out of the seat altogether. In play, they wander from toy to toy, only temporarily entertained. On the other hand, a child like this can be enthralled by the television, rhythmically bouncing or frozen in front of the beloved screen so that the rest of his surroundings appear to fade away. Other favorite activities such as drawing or building with tiny blocks may also hold him spellbound for long periods, but as a rule, his attention lasts something closer to a few moments. There are other perplexing contrasts with these youngsters. Although they may have been early climbers, walkers, or runners, frequently these kids are so noticeably clumsy that they wear bruises and bumps like batches across their bodies. Many parents are embarrassed by the number of times they must make unscheduled trips to the doctor or emergency room. These accidents have more to do with rashness than awkwardness. These children simply tend to leap before they look with little or no thought to the consequences of their actions. Most parents of ADHD youngsters immediately recognize their own child from such descriptions or at least from portions of them. There are, however, children who present a very different set of characteristics who also show early signs of an attention deficit. Some babies and toddlers are so underactive they are labeled hypoactive. Much of their time is spent sitting contentedly, holding a toy, neither starting nor playing with it, with only fleeting interest in anything new. They appear almost unaware of what is going on around them. When they do attempt to retrieve an item, they are bound to be sidetracked by an endless number of distractions that would scarcely draw anyone else notice. As they get older, questions about why didn't you do what I asked are met with that blank stare that drives parents up the wall. The disturbing behaviors parents first recognize are often those noted frequently in histories of children later diagnosed as having problems with attention or hyperactivity. Com- Compiling these behavior characteristics, we have developed a list of early warning signs of ADHD children. Use the early warning checklist presented on page 21 to review your child's behavior. A child who has ADHD may match the descriptions completely or have only a few of the symptoms. On the other hand, the fact that your child's behavior corresponds to a few of the items in the list does not complete a diagnosis. Probably, most of the children who exhibit selective attention to a parent's requests or who are occasionally enraged by the television or a video game are not ADHD. This is one time when comparisons with other children of the same age and sex can help you make this distinction. Observations of your child playing with peers in an organized activity at a playgroup or at preschool can provide relevant information. Be aware, though, that initial shyness or excitement can magnify traits that fade once a child is comfortable with the rest of the individuals involved at the situation. Preschool teachers who have had experience with many different children are a valuable resource for you. There is no score for our checklist, but the more items to which your answer yes or the more strongly your child demonstrates a particular behavior, the more likely that behavior may be an early sign of ADHD. The checklist will help guide your observations of your child provided he is below the age of 5. Whereas if your child is already in school, think back to what he was like as a toddler. Early warning checklist. Was your child much more active in the womb than his siblings? Did your child have trouble establishing a normal sleep pattern? And does he still require much less sleep than his siblings or same age peers? Is your child much more squirming than his peers, especially in situations that require him to sit still, such as at meal times, when riding in the car, when sitting in restaurants? Does your child switch from activity to activity more quickly than the average child his age? For example, does he have trouble playing with most toys for as long as designed or in the manner a peer would? Does your child normally have trouble taking turns or waiting for the simplest request of the full to be fulfilled, such as getting him a drink? Is your child not just a climber, but a constant scaler who ends up on top of things and in places other children only dream of but wouldn't dare try to reach? Has he ever gotten onto the top of the refrigerator, been stuck in a tree, or climbed onto the roof? Is your child a daydreamer who looks at you with blank stares as you talk to him? Now, medical exams. When a child continues to show signs of impulsivity, distractibility, or hyperactivity, then the first formal step if diagnosis is to discuss your concerns with your pediatrician or family physician. A number of physical problems that look like ADHD should be ruled out before a true diagnosis of a primary attentional disorder is made. Many of these conditions are rare, but that makes it all the more important to eliminate them before proceeding. If they are present, you will want to treat them immediately. Many of these things your pediatrician or family physician will be looking for are discussed in this section. Thyroid disease. The thyroid is a small gland located in the throat near the Adam's apple or larynx, which regulates many important body functions, including metabolism. Either an overactive or underactive thyroid gland can cause symptoms that emulate ADHD. A condition called hyperthyroidism induces this gland to overproduce hormones, causing the body to speed up. As a result, a person may feel jittery and appear restless, much like an individual who is hyperactive. If the thyroid produces an inadequate amount of hormone, this can lead to a condition called hypothyroidism. When this occurs, a person's metabolism may slow down, causing him to gain weight and feel sluggish. The individual may appear daydream, be distractible, or to tune others out. It would not be at all surprising if he had trouble remaining alert during sedentary life activities. By examining your child, a physician can detect signs of an extreme problem. Otherwise, a blood test routinely included in most physical exams will be used to determine if there is a thyroid related problem. Next is hearing problems. As a practical observation, over the years, we had noticed a correlation between children referred to us because they were not paying attention in class and a history of chronic ear infections. These same children had often passed the brief auditory screening conducted at school with flying colors because certain kinds of hearing weaknesses are not immediately apparent in that setting. Only a specialist has the necessary equipment to detect hearing losses of particular frequencies and at various decibel readings that may be permanent or temporary. A child who is subject to frequent ear infections may have congestion in the middle ear that impedes hearing. There are fluctuations in this condition, explaining how it happens that a child with frequent ear infections may appear to pay attention well one day and not another. These losses may also provide partial explanation for why such children show gaps in language knowledge, affecting the child's ability not only to produce sounds and understand certain syntactic structures but also to develop vocabulary. Sometimes children who have these kinds of problems concentrate better when they take antihistamines. Do not confuse this with the assumption that the child would also respond to medication for ADHD. It is more likely the child attends better because his hearing has improved as a result of medication, allergies, and upper respiratory illnesses. There has been a great deal of controversy over whether allergies are the cause of attentional problems. Dr. Ben was one of the leading proponents of the theory that hyperactivity and attentional deficits are caused by allergies to food additives. Others believe that sugar is the primary culprit. To date, no convulsive scientific evidence in any large sample of children has been found to support the theory that food reactions cause ADHD symptoms. There are parental and clinical reports of particular children being affected by such factors, but research shows it is highly unlikely that this is the source of these symptoms for the vast majority of ADHD children. On the other hand, a number of children who have attentional problems are allergic to airborne substances. These kind of allergies can affect a child's concentration when a child has several periods of time each year during which he is congested, has difficulty breathing, and spends his time blowing his nose or sniffing. His concentration during the day and his sleep at night are both being frequently interrupted. Consequently, the youngster is likely to feel tired and less energetic and therefore less tuned into what is going on around him. Many children we see for assessment are noticeable more distractible and restless on days when they are suffering with stuffy noses and watery eyes. Not only do they look like ill, but their performance is affected as well. With a little detective work, one may discover a pattern of less successful school performance that corresponds to the seasons of the child's allergic reactions. Unfortunately, diagnosis and treatment for allergies alone do not always remedy the situation. Sometimes allergy treatment complicates the situation. Breathing may ease with treatment, but a number of medications commonly prescribed to open airways have side effects that interfere with concentration. Some prescription drugs and over the counter remedies may cause a child to become agitated or drowsy so that concentrating in the classroom is very difficult. Neurological problems. Sometimes a child's problem attending may be caused by neurological problems. On rare occasions, a child's blank stare into space may be indicative of a very small or petit mal seizure. These are brief periods during which the child is totally unaware of his surroundings and afterwards may be unable to recall what occurred. As brief as a few seconds to as long as a minute or more, these episodes are so dissimilar to what people usually think of as a seizure, what they easily pass unnoticed. The child does not fall to the ground or his eyes do not roll back into his head. There is no danger of the child swallowing his tongue, but a youngster experiencing a petit mal seizure will have a glassy stare, perhaps blink rapidly, and may not respond to questions. Afterwards, the youngster rarely complains, for he tries to hide the fact he does not know what he missed or even why. If you suspect this may be happening to your child, discuss it with your pediatrician or family physician. Your doctor will probably ask to observe your child and may want him to touch his fingertips together quickly or balance on one foot. A child's inability to complete these physical tasks is considered to be a soft sign or evidence of a neurological problem. To complete the workup, your doctor may advise that a specialist conduct further neurological testing, including an EEG, that is electroencephalogram, to reveal any brain wave patterns indicative of underlying seizure activity. Do not panic if some abnormal brainwave activity is revealed. The degree of abnormality is the important factor. Your physician will explain whether the pattern is one that may lead to more full seizure activity. Fortunately, most childhood seizure disorders can be controlled by medication. Do not same not the same one used for ADHD, and often children outgrow such problems. Now we come to parent questionnaires. As a parent, you have had a unique opportunity to observe your child in a variety of situations. You have the advantage of living with him day in and day out. Clearly, you have a good deal of information about your child that it is important in the diagnostic process. The problem is how to organize that information in ways that will be helpful to the professionals who are working with your family. A physician, psychologist, or other professional can ask questions, but without a means of determining if the characteristics you describe are typical or normal for children your child's age. They will not be able to attach a meaning to any discernible patterns. If it is a virtually impossible for any 2-year-old to sit quietly at a desk for 5 minutes, then the fact that your child cannot accomplish this feat is not unusual. If your 2-year-old regularly sleeps a total of 5 hours a night as compared to twice that amount for most toddlers, that fact becomes significant. To accumulate data on typical childhood behavior patterns and those of children who have ADHD, psychologists have asked thousands of parents to complete a series of questions about their children's behavior. Most of the questions relate to the way children act and respond in typical childhood situations at home and elsewhere. To validate the information collected through these questionnaires, comparisons were made between the answers parents gave and direct observations of the children. The result is a series of parent questionnaires that can be used to compare your child's behavior with that of other children of the same age. When completing a parent questionnaire, each parent should answer the questions individually. If you like, afterwards, you may compare answers with your spouse, but do not change your responses. While the number of forms parents are asked to complete can be a bit overwhelming initially, the information gathered is significant. The process can be surprisingly enlightening. Parents may discover that they have drastically different views of their child's behavior. These contradictions may be disturbing to parents, but awareness of such discrepancies may help pinpoint differences in attitude, perspective, or approach within a household. The professionals working with you can then use the questionnaires as tools to plan unified treatment strategies. You and your spouse can go over your individual answers yourselves. Instead of trying to convince each other of a practical particular point of view, discuss the item attempting to figure out why each of you rated the child as you did. In the process, you may arrive at a new point of agreement about how to deal with a particular situation and clearer rules about key problems that you concern. There are a number of commonly used questionnaires. We shall discuss several of these so that you will be familiar with these elements of the diagnostic process. Very Wiz Peters Activity Rating Scale WWPARS. VeryWiz is one of the easiest questionnaires for parents to use. It contains 22 questions about the child's behavior in a number of different situations, including mealtime, while watching TV, playtime, bedtime, sleeping, and in public applicable to children ages 3 to 9. The questions focus on activity. The information about concentration, distractibility, or impulsiveness is extremely limited, but the instrument has been shown to be sensitive to improvements in behavior due to medication or behavior therapy. Verivis is best used as one of several screening devices to determine if a young child's behavior falls in the hyperactive range. If both you and your spouse have a high score and agree about your child's activity, spouse have a high score and agree about your child's activity level is in most of the situations, then these results increase the likelihood that your child may be hyperactive. Connors Parent Rating Scale CPRS. The Connors questionnaire, developed by C. Keith Connors, PhD, is probably the most widely used of all parent questionnaires for ADHD. Over the years, many studies have been conducted showing its effectiveness in distinguishing between ADHD youngsters and those who do not have this disorder. The 48 question version yields scores on a number of problems, including conduct disorders, anxiety, learning problems, psychosomatic symptoms, impulsivity, hyperactivity, and a hyperactivity index. Although the questionnaire has been criticized as too limited in the number of items related to anxiety and pure attentional deficits apart from hyperactivity, it is a helpful measure when considered as a part of complete diagnostic package. There are Also, brief parent and teacher forms in the corners questionnaire that has been shown to be sensitive to changes in the child's behavior and that are easy to use for monitoring behavior. Next is Home Situation Questionnaire HSQ. The HSQ, developed by Dr. Russell Barkley, is another relatively easy to use instrument that can help to distinguish typically from ADHD behavior patterns. The questionnaire lists 16 different situations for which a parent indicates whether or not the child has problems and if so, how severe. If a child has high ratings in 7 or more areas, his behavior probably parallels that the ADHD, youngs- ADHD youngsters. This questionnaire is most useful to a clinician as an indicator of where a child's problem occur most often. Since these ratings cannot directly measure activity level or attention span, a child may score high on this scale because he has behavior problems, not ADHD. Teacher ratings. Just as you have been in a distinct position to watch your child over the years, so too have his teachers, particularly in regard to a child's attentional abilities. They have seen him attempt to concentrate on a variety of tasks and noticed how much his environment and the students in it distract him. If a child is impulsive, rushes to begin tasks before the instructions are complete, blurts, blurts out answers to questions and finds it nearly impossible to wait his turn, it is obvious to teach. On the playground, overactivity is not immediately apparent, but once a child enters the classroom, he must sit down. A teacher also has the advantage of comparison. Having taught school for a number of years, a teacher has worked with many students. In your child's classroom, in front of her eyes are other children, offering an immediate comparison. The contrast among behaviors is obvious. A number of research studies have found that teachers' ratings on various scales may be the best predictors of which children are ADHD. The more of your child's teachers who rate him as ADHD, the greater the likelihood that the child really has an attention deficit. Connor's Teacher Rating Scale, that is CTRS. Probably the best known and most widely used teacher questionnaire, the CTRS consists of 28 questions that yield scores of on your four factors: conduct problems, hyperactivity, inattention, passivity, and hyperactivity index. This instrument is more sensitive than the parent's form of Connors to differences between hyperactive children and those who are not. When a child's teachers complete the questionnaire, the comparison of their observations has proved to be significant a source of information for the diagnosis of ADHD. The teacher rating scale also appears to reflect the effects of medication or behavioral interventions on a child's behavior. Other questionnaires. There are a number of other teacher questionnaires. The Child Behavior Checklist CBCL by T.M. Achenbach is composed of 112 questions. In regard to each behavior described, the teacher responds not true of the child, somewhat or sometimes true or very true, very often. When scored, this instrument yields ratings on anxiety, depression, aggressiveness, delinquency, withdrawal, obsessiveness, and somatic complaints, as well as hyperactivity. The value of this measure is that it sorts out a variety of reasons why a child may be acting in a particular manner. For example, if the child is very anxious and acting compulsively, it will affect his concentration. The CBCL does a much better job of defining emotional and behavioral factors that does the CONUS. The ADDH Comprehensive Teachers Rating Scale is another new scale that primarily focuses on characteristics of attention deficits and hyperactivity. The questions completed by the teacher seem as effective as the quiz in measuring hyperactivity, but may be more accurate on in delineating ADD without the hyperactivity component. Next is psychological evaluation. The notion of taking your child to a psychologist for testing, though, is not obscure, cryptic, romantic, mystical, or miraculous, and it shouldn't be frightening. Psychological evaluation is a very straightforward and routine process. From your child's point of view, he will be drawing, completing puzzles, answering some questions, and performing a variety of tasks that look similar to the one his teacher asked him to do at school. During their time together, the psychologist will work with your child not only to obtain measures of intellectual potential and achievement but also to gain some indication of child's emotional well-being. These sessions provide many opportunities for the psychologist to observe how your child reacts to frustration, how long he is able to sustain his attention and concentration, and how he responds to time constraints. By means of interviews, paper and pencil tests, and direct observation, the psychologist will evaluate how anxious your child is, what his overall level of happiness seems to be, and what his self concept is in terms of school, family, and friends. Other emotional factors that might be affecting him will also be explored. Psychoeducational testing should also identify any learning disabilities or processing problems that make it difficult for your child to complete your work or stay on task. As a result of psychoeducational testing, you should be able to find out whether your child is overachieving, underachieving, or doing work at the appropriate level of his ability. Your child's need to achieve and his level of motivation will also be considered, even though these are not exact measures. Finally, the psychologist may use a number of methods, including several computerized tasks like those included in the Gordon diagnostic system to assess attention span, concentration, distractibility, and impulsiveness. You might assume that from this collection of information, an exact diagnosis can be made. Unfortunately, psychology is not a science that yields isolated results to draw any conclusions about whether ADHD is a part of or all of your child's problems, the specialist must interrupt the course of the psychological psychoeducational test in terms of everything else that is known about your child. No psychological exam exists to diagnose ADHD definitely. In fact, many youngsters are able to sit still and concentrate quite well throughout an entire psychological assessment, but are incapable of maintaining that same stance in a noisy classroom full of distractions. Pulling it all together. You have visited the specialist, your child has taken the test, been examined and observed, you have answered the questions and completed the forms. Quite a lot of information has been compiled about your child. Most of the time, the long awaited simple yes, he has it, or no, he doesn't, is not forthcoming and may not suffice anyway. Someone must sift through the data, determine the diagnosis, and plan a course of action. Frequently, one of the professionals takes charge, but in many instances, you will need to assume an active role in coordinating the communication between the various experts. By now, you have a collection of reports and results. Read the reports carefully with marker in hand. Highlight those parts that don't make sense to you or the conclusions that conflict with each other or your own assessments of your child's behavior. Then compose your questions and get ready to direct them to the appropriate professional. It is always more efficient to collect your questions from each specialist in advance. Some parents worry that their questions will appear foolish. There is no need to worry about that. Your questions reflect your concern, and that is what counts. As you discuss the results, speak up, point out the inconsistencies you see, asking each professional for an opinion. Prompt each specialist to talk with others who have been involved in the diagnostic process until the contradictions are resolved and a final diagnosis is made. You must be aware that your child's age will be a factor in diagnosis. While it is always better to discover problems as early as possible, particular difficulties come into focus only as a child develops. Except in the case of the most hyperactive children, assessing attentional deficits is hard to do in the very young child. If a child's weaknesses are mild or due to several factors, it may be hard for any professional to draw the definite conclusion. Even when you understand the diagnostic process, sometimes you will not get the definitive answer you seek. Use the information you do receive to pinpoint the various causes of your child's attentional problems. We have developed a diagnostic checklist below that will help you pull the information you have gathered into usable form. Medical. Be sure to discuss this with your physician. Does your child have any medical problems that may in any way affect his ability to sustain attention? Do any of the medications your child takes for any condition have side effects that could interfere with concentration or memory? Does your child have vision or hearing problems that would make it difficult him to follow directions, comprehend oral instructions, or do written work? Does your child ever stare into space and have lapses in memory about what just occurred? Does your child have frequent headaches? Is your child clumsy or more accident prone than children of his age? Next, psychological. Does your child show signs of nervousness or anxiety? Some signs to look for are nail biting or other nervous habits, cold, sweaty palms, upset stomach before tests, excessive worrying, trembling, or other overt signs of being tense. Did the psychologist or learning specialist note signs of excessive anxiety during testing? Did your child's performance on psychological or educational tests or any ratings completed by teachers or parents is indicative excessive anxiety, depression or conduct problems that could be the primary disruptors of concentration? Did testing reveal that your child is preoccupied with other thoughts that could be blocking him from attending? Is he worried about making or keeping friends, achieving in school, or getting along with peers and siblings? Are there conflict and other problems occurring within the family that may cause your child to be worried or depressed? Is your child frequently angry or at times aggressive? Next, educational. Did your child's testing reveal deficits in particular skills such as reading, math, or other subject areas? Are those gaps large enough to make it difficult for your child to complete his work in a reasonable amount of time without frustration? Did testing indicate any processing problems of or learning disabilities that interfere with your child's acquiring new learning, retrieving old information, or expressing what he already knows orally or in written writing? Can your child listen and follow directions at a level they are given in the classroom? Does he need instructions broken down and repeated before he is able to correctly start a task? At his current class placement, is your child able to keep up with his peers academically? Does he compare himself only to the best students in each subject area so that he feels inferior? Behavior or attention? How many of the parent and teacher ratings yielding results that were significant for hyperactivity, short attention span, impulsiveness, conduct problems? Did direct observations of your child by an independent rater find a high incidence of off task behavior during class time, diagnosis is not an end. While many of us prefer the security of labels and statistics, the results are important only if they lead to help for a child. Whether your child fits the diagnosis of ADHD or not, he displays behaviors that trouble you, impulsivity, distractibility, inattentiveness, or overactivity. The remainder of this book will be about how you can help your child with each aspect of his problem. We are ending here with chapter 2. We will start third chapter, that is motivating your child, in another part.